Okay, recording now.
It's kind of, yeah, perfect. So this is just, one of those cases. Don't let this happen to you. So, your regular consult
My
from,
favorites.
yes, they're certainly my favorites too. So consult from GYN surgeon saying, I have this patient that comes from another hospital. I have no idea what this report says, what those images shows. Okay, let's have a look. So first of all, this is from GYN. So yes, there are bilateral ovarian masses, there are septations, and there is some soft tissue enhancing component. And then, and here are some coronal images on the CT, and you can see also, I show it to some degree, that there is a left-sided hydro.
Was the patient trying to get pregnant?
No, she's 58-year-old.
Oh, 58, sorry, I missed the age.
Yes, so, and very good question, always ask about clinical presentation. When the request comes from the GYN onc, you kind of assume that this is some sort of pelvic pathology, but then you start looking further on. And here we have a few more findings. So we have, this is in the middle of it is a gallbladder, and there's a stone stuck in the neck of the gallbladder. There are some stones here, but there is also kind of infiltrating hypodensity around the gallbladder. Throughout all those images, I think I have a little bit more. I'll have more a little bit later. There is no enhancing component anywhere. Yes, there are stones in the gallbladder. Yes, there is this big infiltrating mass. There is all this fatty straining and a little bit of fluid in the kind of right upper quadrant. And then
why do you say there's no enhancing component? I see, like, for example, that top left image to me looks like a hypo-enhancing mass.
This?
Yeah.
For this. So this is the liver adjacent to that. I will show it a few more images to you later, also MR of this. Yes, you're right. We shouldn't be really talking about hypo, lack of enhancement, or true enhancement unless we have a non-contrast and then compare to the enhancement. But overall, all of this was very simple. There is no like mesh-like component anywhere. When we go down, what you see, this is actually below the liver, and there is basically a couple of stones and in the left lower quadrant as well. And there are basically some fluid collections around those stones. So one of the diagnoses that I was entertaining was basically that at some point she had some acute cholecystitis, she ruptured, and this is all basically enhancement due to the abscess and into this adjacent liver. That's another option, Nelly. Yes. The patient also externally underwent MR, and here are a few more images. So this is just T2 showing you the how high signal this is. This is the gallbladder itself. Yes, there are stones, but there is no soft tissue in the gallbladder, and the walls looks pretty smooth on those
Actually,
images.
we have this case come up a lot, which is like a mass adjacent to the gallbladder, and they'll ask, is it a gallbladder mass invading the liver, or is it an intrahepatic cholangio adjacent to the gallbladder? This case with the gallbladder looking like that, I would say if it looked clean all the way through, this is more likely an intrahepatic cholangio or a MET.
Okay, fair enough. So here are a few more images. Again, and we see this kind of peritoneal stuff here. Coronal images, which certainly does not, it's very heterogeneous.
I take it back. It doesn't look like it's gallbladder in origin now.
So yeah, so you see the gallbladder itself?
So clean now.
Exactly, right? But then you have all those stones outside of the gallbladder. So what the heck happened here? Sorry. And then you also see that stone that is stuck in the neck, right? So this is post-contrast coronal, and this is axial T1. Diffusion. Tell me, guys, if it helps you. But then again, if our consideration, differential diagnosis varies between the abscess versus tumor, that's, both of them can restrict. There's potentially some restriction around the gallbladder. Post-contrast images.
Oh, wow.
Yes, what?
Now I'm like leaning towards infection.
Yeah, okay. So
I'm
Abscess.
still
this,
with intrahepatic cholangio.
Ah, really?
we'll have to take a vote. You'll
What
have
was
to
the
take a vote.
breakout? Breakout. Was the patient febrile?
Okay, just a second, just a second. So here's the wall of the gallbladder, so nicely enhanced. And here you kind of don't see the enhancement, which kind of made me personally more suspicious of rupturing gallbladder and basically having all this abscess into adjacent gallbladder, into adjacent liver. If you look through, there is like, so this is not enhancing, but there is all those bits and pieces of adjacent liver that are still enhancing, but could this be just an abscess? Certainly could. Subtraction images showing pretty much the same thing. Gallbladder wall, there is discontinuity in the medial wall, but again, no
Victoria hasn't
soft
said
tissue
anything yet.
whatsoever. Sorry?
Victoria hasn't said anything yet.
Uh-oh. Yes, the patient certainly has diabetes. So, you know, one of the things that I was considering, whether this is acute cholecystitis, she's been sitting on this for a while, this is ruptured, and she's not really complaining too much because she has diabetes. Yes, she does have diabetes, but then again, diabetes is very common, right? Here is just a few more images of the pelvis, of the regional consult, right? So bilateral ovarian masses, there is definitely a lot of soft tissue on the left, and there is a left-sided hydro. So we can vote at this point. So who is for abscess and perforated gallbladder with abscess versus
Where's the white count?
tumor?
Was
No,
she never?
yeah, she was like, she had abdominal pain. She has abdominal pain, and when you ask her, yes, she actually had right upper quadrant pain for a couple of months. And
I think she has intrahepatic cholangio with Berg tumors. You always want to exclude the metastatic disease because that's much more common. Breast and colon cancer are much more common than cholangio. So definitely get her a mammogram and a colonoscopy. But otherwise, I think these are Krukenbergs and a tumor.
okay. So she, so the next step was requested the biopsy, and when you look at that, I don't think at that point I was doing this biopsy, I was like, okay, that's definitely not infection, that's definitely not abscess, even though the gallbladder looks very smooth and nice. So probably you're right, Artie, this is coming from the adjacent liver. And a few more images, kind of very large infiltrating mass. And that's her symptoms. So basically right upper quadrant and shoulder pain for 4 months. The Klinger is this. So yes, this is all has been elevated, certainly, but also CA125, right? So, but CA125 is not very specific. And here are biopsies, and biopsy number 6 and biopsy number 10. I really wanted to make sure that I'm not getting any necrotic tissue, right? So the question here, when you do the biopsy, you know that most of this is non-enhancing, right? It's non-enhancing. So am I just going to biopsy necrotic components? So that's why I went and biopsied all parts of it that I thought were more viable, but all of it came back as cancer. So this was, they basically said most suggestive pancreatic or biliary origin. So we don't know if it's a gallbladder versus cholangio, but most likely it's a cholangio. Now, just a few words about Quicken tumor, which was kind of a fun part. So it was described by Frederick Ernst Krukenberg as a primary tumor of the ovary, actually, called fibrosarcoma, and only 6 years later, this was determined to be actually metastatic disease from GI tract. 7% of ovarian tumors are METs, and only 1% of them are biliary. So most of it, everything else should be, it's either colorectal, gastric, or breast. The patient did undergo rest of the evaluation, and there was nothing else. So it is probably intrahepatic cholangio. And yeah, and it's actually pretty rare. This is a case report that just was published last year. So that's it. Any questions?
Olga,
Great
did
case.
we ever, sorry, quick question. Did we ever biopsy what looked like peritoneal deposits like near the liver? Was that,
No,
we
but
didn't?
we assumed that basically this was continuation of the same disease.
Correct, okay.
Yeah, and intrahepatic cholangio can spread directly. So like when the omental induration right along the tumor doesn't necessarily mean they have omental disease. So it could still be in the local kind of staging. But yeah, that was a great case.
Yeah, and I do think that she did rupture it at some point.
Yeah.
The gallbladder
Oh, I
was
mean, the
ruptured.
gallstones all over the place. That was like a red.
Yeah. Yeah, that which was obviously kind of directing me to completely wrong conclusions. But
I
yeah,
have a question. Do you ever biopsy Quicken tumors? What is your policy or stance on biopsying like cystic ovarian masses?
so I just had another discussion with Joanne Ong. I will never do it unless I talk to Joanne Ong. Because basically if it's a primary tumor, if it's all resectable, you should not. And if it's not ruptured, you should not touch it. But if it's already ruptured completely, then, and there is no other way and there is no plans for laparoscopic or surgical resection, yes, you can biopsy the primary tumor itself. But basically the problem is that you will rupture it by sampling it. And then it's upstaging.
Yeah, yeah. So if they're already peritoneal disease. And then I've noticed too that if people have bilateral ovarian masses, I used to just kind of jump to like, these must be Mets, these must be Kirkenbergs. And then I realized that some people have like bilateral ovarian cancer and kind of probably spread in both directions along the fallopian tubes. And so now, you know, if it's bilateral, but you don't see anything in the stomach, liver, pancreas, it could just still be primary ovarian cancer.
Yeah, that's actually pretty common, bilateral ovarian disease. And sometimes it's microscopic, but in many cases we do see something there.
Well, awesome. Thanks for sharing.